All right, I believe we are ready to get started here. All right, so let me go ahead and move this 1 second. There we go. Okay, go ahead and begin then. All right. Hi, everyone. Thank you for attending this panel today, which we have named Health Literacy and Cognition, a review of 15 years of findings from the LitCog study and beyond. The Health Literacy and Cognitive Function Among Older Adults study, or LitCog, is conducted at Northwestern University's Feinberg School of Medicine in Chicago. And so this photo here is our campus, and this building is where our center operates from. Let me show that to you guys really quick. That'll be right over here. And we also have a research suite closer to the hospital where patient interviews are conducted. Northwestern promotes an ever-growing community of clinical and aging research scientists with a wide range of resources available to the research enterprise. So now I will share the panel overview and introduce the speakers for today. All right, so my name is Morgan Bonham, a research project manager for the Center of Applied Health Research on Aging. I'll be providing introductions for the rest of the speakers and also provide a brief overview of the LitCog study today. And then following me is Francesca Tomasino, a LitCog research coordinator. She'll be speaking to a few insightful findings from the study. Next is Laura Curtis, research associate professor. Ms. Curtis will be sharing results of changes in cognitive function and health literacy over time. Dr. Rachel O'Connor is an assistant professor presenting on the LitCog caregiver cohort. And the last speaker will be Pauline Zhang, who is a project manager, and she'll be introducing you all to the MidCog study, which is a newly launched middle-aged cohort that aligns to LitCog. We'll also reserve some time at the end for Q&A. Feel free to leave any comments or drop any questions into the chat as you have them. We'll pull those up at the end. So first, I'd like to acknowledge the principal investigator, Dr. Michael Wolf, and our many co-investigators and collaborators from several institutions, including Northwestern, Icahn School of Medicine at Mount Sinai, the University of Edinburgh, Mercy Hospital and Medical Center, and Access Community Health Network. We also have many early advisors that have contributed significantly to our work over the years. I also wanted to take a moment to thank the study team and our community. Sorry, that one just pops ahead for some reason. Our community partners for their contributions to the LitCog study. We have wonderful research participants that have graciously dedicated several hours of their time to our research activities. Lastly, I want to recognize the National Institute on Aging, the funder that supports this research. So health literacy, what is it? In the past couple of decades, the field of health literacy has really grown and emerged as a topic of great interest. Yet the term health literacy can be challenging to define as it continues to be an evolving concept. A few of the most recognized definitions appear on this slide, as well as the most updated definition coming from Healthy People 2030. But what we want to highlight is that at the cornerstone of all of these definitions is the common element of cognitive, brain-based skills or thinking skills. So keeping this in mind, I want to take you through the history of LitCog and how LitCog came to be. All right, so we will start with 1989 because this is the year that Dr. Wolf graduated from high school. But this is also the time of early health literacy research, when definitions around health literacy just started to emerge, and that health literacy is a major determinant of health. Then in 2004, the National Institutes of Health launched the first program announcement calling for health literacy research. And in 2006, there still had been little evidence of studies attempting to explain health literacy's impact on health outcomes via cognitive function. So this is when the LitCog grant proposal was submitted. In 2007, we were funded by the National Institute on Aging and had 2 subsequent renewals for the grant. And in 2019, with an administrative supplement and our 4th renewal, we expanded our investigations to formally include caregivers of LitCog participants. And then in 2021, Dr. Wolf started a new cohort of middle-aged adults that have aligned their methods to LitCog's. But right now, I would just like to focus on the specific objectives of LitCog. So initially, a cross-sectional study with LitCog 1, the original objective of the LitCog study was to investigate the relationship between health literacy and domains of cognitive function in older adults, and to determine how these factors predict performance on self-management tasks. LitCog became a cohort study with its first renewal. So with LitCog 2, we were able to now look at changes in cognitive function, health literacy, and self-management skills, but also their associations with physical and mental health status. With LitCog 3, new health behaviors, chronic disease outcomes, and healthcare use were obtained from the medical and pharmacy records a decade post-baseline. With an administrative supplement, we were able to start investigating the involvement of caregiver support. So with 6 assessments over 15 years at LitCog 4 now, we are able to look at specific trajectories of decline in cognition, health literacy, self-management skills, and health status can be better studied. And then we also received an administrative supplement looking at the impact of COVID-19 among older adults. We recruited 900 patients who were between the ages of 55 to 74. Participants were recruited from 1 general internal medicine clinic and 6 federally qualified health centers in Chicago. Participants were community dwelling and had to be functionally independent and cognitively normal adults. 2 face-to-face interviews were conducted 7 to 10 days apart every 3 years. The study team selected gold standard assessments with a combination of pen and paper activities and computer-based games. The cognitive battery was developed by Cambridge Cognition, which is a leading neuroscience technology company. And in addition to multiple health literacy assessments, routine healthcare scenarios to assess self-management behaviors and patient-reported outcomes. And as mentioned, caregiver support was a new objective, and we began to identify if LitCog participants had caregivers. So at time point 4, 220 caregivers were enrolled. And Dr. O'Connor will talk more about this part later. On average, participants were 63 years old, 69% are female. The sample is diverse in terms of race and socioeconomic status, and participants had 3 chronic conditions. But as you can all probably guess, we ran into a problem after receiving our 4th renewal. COVID halted research activities and presented a unique challenge with continuing in-person interviews, especially with older adults. But knowing the importance of retention in regards to this longitudinal cohort study, we continue to engage with study participants by conducting phone interviews for time point 5, as well as supplemental phone interviews regarding COVID. We are fortunately now back to doing a combination of in-person and phone interviews at time point 6, which is what we're doing right now. However, the phone interviews completed at time point 5 and the hybrid data collection methods at time point 6, we have been able to stay more connected with participants, even as you can see on the map. Some of the patients have moved away from Chicago. But most important to note is that a large majority of the participants still reside in the Chicagoland area and are available for follow-up interviews. So with that, I am going to be passing this over to Francesca to begin her presentation on cross-sectional investigations.
Great, thank you so much, Morgan, for giving us that introduction on the LitCog study. My name is Francesca, and I'm going to be talking about the cross-sectional investigations of cognitive function as a determinant of health literacy skills. So first, to go back to our objective for the study, it's to investigate the relationship between health literacy and specific cognitive skills. So to begin, we're going to have our first question, which is health literacy correlated with cognitive function? So the health literacy measures that we used in our study, we administered the full TOEFL, the NVS, and the RELM. The measures differ in terms of content and abilities measured, and the TOEFL is a timed test involving reading comprehension based on common language used in medical settings, and 50 items where you fill in the blank. It also has a numeracy component based on common directions provided at doctor offices, and the scores are classified either as inadequate, marginal, or adequate. The second health literacy measure we use is the NVS, and it involves reading and numeracy applied to the interpretation of a nutrition label. And our last one is the RELM, which involves the correct pronunciation of medical terms, and the score is based on the number of words that are pronounced correctly. So these accompany our cognitive measures. So the participants completed 3 measures from each of 5 cognitive domains. And these are the measures that make up the entire battery that we administer to our participants. So 4 of these domains, specifically processing speed, which is how fast you understand and react to information, working memory, which is the ability to focus attention to organize and apply information, inductive reasoning, the ability to critically analyze and solve problems, and long-term memory, the ability to recall information days or even weeks later. Those are considered our fluid abilities that are seen here on the left side, or the abilities that are necessary to actively learn new information or solve problems. Verbal ability here on the right is more of a crystallized ability, which means that it's more strongly dependent on background knowledge and information that you've acquired through your life, such as vocabulary. So, as seen in this table, the health literacy measures, the TOEFL and the NVS, have more similar associations with different categories of cognitive ability, which represent fluid skills such as processing speed, working speed, inductive reasoning, etc. And the exception here is the crystallized cognitive ability. So that's where we see that the 3 measures are rather closely associated here at the last line. And so that's to say that fluid ability does also contribute to crystallized ability, which is seen with the RELM measure. So health literacy measures were strongly correlated with all cognitive abilities. Fluid abilities were more strongly correlated with the TOEFL and the NVS than with the RELM, and crystallized abilities correlated similarly with all health literacy measures. And that takes us to our second question, which is, to what extent does cognitive function explain health literacy's associations with self-care capacity? So in order to look at self-care capacity or self-management capacity, we have the CHAS, which is our measure that we use. It was developed for the LitCog study, and it includes 10 different healthcare scenarios. It speaks to these 5 domains to see if our participants can comprehend print information, recall spoken information, recall multimedia information, organize dose medications, and healthcare problem solving. So here the image on the top left shows the graph that we show our participants in one of the tasks where we have them decide which nursing home would be a better one. On the right is our task where we have them dose out their own medications. We provide them with prescription label bottles as well as a box, and they have to dose out their medications throughout a day. On the bottom left is the chart that we provide them with daily blood sugar readings, where we ask some more numeracy related questions. And on the bottom right, as some of you may recognize, is Dr. Baker. We show our participants a 3-minute video where he describes acid reflux disease, and then we have some recall questions for them. So after using our CHAS measure, we're able to see that first, health literacy is associated with one's ability to self-manage their health, so take care of their healthcare needs and independently understand requirements of self-care. So that's what we see here all the way in the left with model 1, where we're only looking at health literacy. Models 2 and 3 show that crystallized abilities as well as fluid abilities contribute to health task performance pretty much almost equally. And our 5th model here, all the way on the right in the red box, accounts for crystallized abilities, fluid abilities, as well as health literacy, and shows that about 2/3 of the relationship to health task performance is described by crystallized and fluid abilities, or what we speak of as cognitive function. So this was true for all the measures, the NVS, the TOEFL, and the REALM. And these results speak to the idea that there's likely not just a limited set of skills that can be isolated as the most important in managing your own health. So the roles that we assume in healthcare require reading and numeracy, but also other health-related knowledge, critical thinking skills, memory, etc. And now for a third question that we look to answer is, to what extent does cognitive function explain health literacy's associations with health status? The forms that we used to look at health outcomes were the PROMIS forms. So we looked at anxiety, depression, and physical function. So these are short form subscales. They're patient reported. We ask how they've been feeling in the past 7 days. For the physical function form, a higher score indicates better function. And in the depression and anxiety forms, a higher score indicates more problematic symptoms. So these have scores in the ranges of 7 to 35 and 8 to 40, and they're normalized to the population. So now looking at patient-reported outcomes from the PROMIS measures, LitCog replicated what other studies had already found, which is that health literacy is associated with physical and mental health. And 40% of this relationship is explained by crystallized abilities and fluid abilities. So the second thing that we're seeing here is that inadequate health literacy, as measured by the TOEFL, was independently associated with worse physical function, greater depression, but not as associated with the anxiety form. So anxiety actually just has the strongest association with cognitive function. The third thing we're seeing is that weaker fluid cognitive abilities are also significantly associated with poorer physical and mental health. So today we've talked about how health literacy is some of the baseline findings from the LitCog study is that first, health literacy is in fact associated with cognitive function, crystallized and fluid. We also see that cognitive function explains a large part of health literacy's associations with self-management abilities. We also see how health literacy and cognitive abilities are associated with physical and mental health outcomes. So back to what Morgan spoke about with our current definition of health literacy, this kind of speaks to the fact that the health literacy needs to be pre-conceptualized to consider not just our cognitive abilities, but to also consider a more expanded skill set, which contributes towards our experience with the healthcare system. So our results also show that additional abilities beyond just reading and numeracy are really important to our own health and our healthcare. So this makes sense, especially when you consider a patient's role in maintaining their health, especially when they have 1 or 2 or 3 chronic conditions, such as our population. So an individual has to engage in active problem solving to successfully navigate the health system. And this is again relevant to the consideration of how to make the healthcare system easier to navigate for those that have lower cognitive abilities or health literacy. And yeah, so next we have Laura Curtis, who's going to talk about how health literacy and cognitive function have changed over time.
Great. Hello. So yeah, as Francesca mentioned, I'll be talking about the change in health literacy and cognitive function over a decade. So it's well known that cognition declines as we age. And but really it depends on the type of cognitive ability. So here you can see Francesca already kind of went through this, but just to reiterate, because it's important for this presentation, the fluid abilities involve reasoning, ability to learn new things and to think abstractly. And crystallized abilities are more based on past experiences and it is stable or increases with age. So an early investigator on LitCog, Dr. Denise Park, looked at cross-sectional relationships between cognitive performance and age across a variety of measures. So the fluid abilities are in the cool colors and clearly decline with age. This study started from the 20s to the 80s. The crystallized abilities are in the warm colors and they tend to increase with age, likely due to gained experiences. We've also shown strong associations between cognitive function and health literacy, as Francesca presented earlier. And therefore, it may be reasonable to suggest that not only does cognitive function decline, but one's health literacy skills may also be affected by age. So back in 2015, our team replicated this analysis in the LitCog sample at baseline with cognitive performance by age group and added the 3 health literacy measures in the LitCog study. The results are summarized in this figure. The fluid cognitive tests are the dotted lines in the warm colors. And some of them start to decline in participants in their 60s, but most of them don't begin to decline until after in the 70s. Now looking at the and then the verbal ability is the green, and that one actually did increase a little, or went up a little, but then it did go down a bit in the 70s, but was similar to those at 50. So I think there just may have been a little fluke in the 60 to 65 to 69 group. And now looking at the TOEFL and MBS, the solid lines are, they're the solid lines in shades of blue. I know it's kind of hard to see, but they perform similar to the fluid abilities and were much worse in their 70s. So our next objective was to extend cross-sectional findings of associations of cognition and health literacy with age to longitudinal associations over a decade. So since the TOEFL and the NBS involved active learning and retaining information, we hypothesized these would perform like fluid measures. And since realm is dependent on background knowledge and is, we hypothesized it would perform like crystallized. Oops. Okay. So for these analyses, we used LitCog data from T1 to T4. As Morgan had mentioned, T5 was all done over the phone, and so those measures are likely different. So we decided just to focus on T1 to T4. We included participants with at least 2 time points. We used multivariate mixed effects of regression, including random intercepts with age and years at each time point as the main variable of interest. And we adjusted for socioeconomic characteristics and number of chronic conditions. We used multiple imputation to account for missing health literacy scores. And we fit a spline effect of age, hypothesizing that some associations may not be linear. So these results were published in JGIM, Journal of General Internal Medicine in 2021. These graphs show splines and 95% confidence intervals for the fluid cognitive measures, or what we thought were the fluid, sorry. On the x-axis is age from 55 to 85,
and performance is on the y-axis. And we adjusted these measures since they had different scales to be on the same scale. So as you can see with the TOEFL, there was gradual decline beginning around age 60 and becoming more prominent after age 75. And then with the NVS, decline really did not occur until age 65, and then more rapidly after 75. And the realm was more linear and remained stable over time. So next, we applied the same analyses to each of the cognitive measures that Francesca described earlier. So all of the fluid measures declined over time as participants aged, and these were with at variable rates. Then for comparison, performance on the TOEFL and the NVS from the previous study that we published are shown in this next graph. We hypothesized that these would look similar to the fluid measures and did find that to be the case. Now looking at the crystallized cognitive measures, these all remained stable and some increased a bit. And again, showing the realm for comparison. So in conclusion, these findings support our hypotheses. The TOEFL and NVS declined with age similar to fluid abilities, and the realm was preserved as with crystallized abilities. Both are important for promoting, protecting, and managing health, but each make unique contributions. We need to consider the global burden placed on patients when designing interventions and determine the best way to support patients. It should be noted that we only investigated 3 health literacy measures. The health literacy toolshed currently has over 200 different measures, and these could also be evaluated in the same way. The measure chosen may have ramifications depending on the purpose. The realm and really any other measures that reflect health knowledge rather than fluid abilities may mask decline in the abilities needed for self-care. And Dr. O'Connor will talk next about caregivers helping the patients out with some of these self-care tasks.
Great. Okay. Thank you, everyone. Hi, everyone. Thank you so much for listening to our talk. So as Laura mentioned, I'll be presenting on caregiver health literacy and exploring its role on older adult health, specifically introducing our LitCog caregiver cohort. I'm very excited to be presenting kind of some initial findings from our LitCog caregiver cohort. I've been involved with the LitCog study in various capacities, first working as a research coordinator and now as a co-investigator. And so just kind of excited to share how the study has evolved over time. Okay, so as we've been mentioning, we've been following our LitCog participants for over 10 years now. So as a result, we've seen a corresponding 10-year increase in their age. So the average age of our participants was about 63 at baseline, and now it's averaging about 74 years at this 5th time point. At the same time, we've also observed an increase in comorbidity and corresponding self-management responsibilities. This graph here shows an increase in the number of participants who are diagnosed with 3 or more chronic conditions and are prescribed 5 or more prescription medicines. At the same time, over this 10-year period, we've also observed a decrease in our participants' physical function. About half of all participants have demonstrated a clinically meaningful change in their physical function from T1 to T4, or about a 5-point change in their score.
And you can see we anticipate this to continue to occur over time as we continue to analyze the data. So these changes that we've observed in both comorbidity, physical function are co-occurring with what Laura previously presented on, or changes or decline in both health literacy skills and cognitive abilities. So to summarize all this, not only are we finding that our LitCog participants have more health-related responsibilities with increasing comorbidity and increasing self-management responsibilities, but their capacity to carry out these increasing responsibilities are also decreasing. So we've observed decreasing physical function, decreasing health literacy, and decreasing cognitive abilities. Okay, so changing gears a little bit, up until this point, we've really focused on the LitCog participant and how they manage their health on their own. But kind of how I view it is that health behaviors and health management often occurs in the context of people's everyday lives. And many people manage their health with other people around them. And so with our aging cohort, we thought it would be helpful to begin to understand the different support that they receive in managing their health. There's many different ways that you can look at different types of social support, but one aspect that we thought was particularly relevant for our older population was the role of caregivers. And so moving to just kind of thinking about how caregivers may be supporting our older patients as they're managing increasing health conditions. It's generally estimated that about 1/3 of all older adults receive assistance in managing their health. And this help really may be able to counterbalance some of the changes that have earlier been described. However, what is often not considered is whether caregivers have sufficient skills themselves to support patient self-management with these increasing complex tasks. So as patients themselves are getting more and more self-management responsibilities, a lot of these self-management responsibilities may be being transferred to the caregivers themselves. So as I think everyone here recognizes, health literacy really is an important determinant of older adult health. But really minimal research has focused on caregiver health literacy and how that relates to older patient outcomes. I think there's been some work looking at parent health literacy and how that relates to child outcomes, but not so much looking at caregivers and older patients. I think not so much of attention has been paid to this population because if an older person has a caregiver present, their capacity to carry out these self-management tasks is often just to be assumed. And so I was particularly interested just in understanding how caregivers may or may not be supporting our LitCog participants, and then among caregivers who are present, just to begin to understand their health literacy. And so with this, we launched our LitCog caregiver cohort in 2019. So we began enrolling caregivers to our LitCog participants. And the objectives of this new parallel cohort is to really first document what assistance are our LitCog participants receiving from either family, friends, or caregivers as they seek to manage their health. And then also to examine associations between a caregiver's health literacy and how that relates to patients' health outcomes, and then to identify any mediating or moderating factors that may be impacting those associations. So in 2019, we began enrolling caregivers to complete corresponding structured interviews. So this co-occurred at the 4th time point, and we continue to follow our caregivers longitudinally, and so they complete corresponding interviews at both the 5th and 6th time points. Our caregivers were eligible if they were 18 years or older. They'd been assisting for 6 or more months, and they assisted with at least one activities of daily living, IADL, or other health management task. And we were purposely broad with our eligibility criteria in order to capture individuals who are providing even sporadic levels of caregiving support in order to ultimately follow their caregiving trajectory over time. Okay, so here you can see the measures and the battery that is administered to our caregivers. The caregivers complete many identical measures to the patients. They do complete measures of health literacy using the newest vital sign, a modified cognitive battery. We assess the caregiver's own health status, as well as collect sociodemographics. And then we also collect caregiver specific measures to understand both the nature of assistance provided, caregiver burden, their self-efficacy, and any healthcare task difficulty that they're experiencing. Okay, so here you can see kind of the demographic characteristics of our cohort. We've enrolled 210 dyads to date. Our caregivers are generally older, an average age of 63 years old. About a little more than half are female, about half self-identify as white, and a third identify as Black. Interestingly, half of our caregivers have limited health literacy as measured by the NVS, which is greater than what we find among our older patients, where only 40% have limited health literacy. Our caregivers are predominantly spouses or adult children, and about 2/3 live with the LitCog participant. Okay, so first, we're just generally interested in understanding the patient caregiver health literacy concordance. Again, we, for the health literacy measure here, we use the newest vital sign. About 2/3 of the dyads have concordant health literacy, so about a little more than a third both have adequate health literacy, and a quarter both have limited health literacy. And then the remaining 1/3 of our dyads have discordant health literacy. So I think overall there is a bit of a spread, and it's not completely concordant among our dyads. So next, we examine the frequency which caregivers reported assisting the older adult with different activities. We found that the majority of our caregivers were assisting with IADLs, such as helping with household chores, shopping, providing transportation or accompanying them with transportation, and even helping with banking. And then much less, only about a third of our caregivers are assisting with ADLs, so personal care, including bathing, dressing, grooming, or mobility, such as helping people transfer or getting around the home. So next, looking at how our caregivers assist with health activities, we find that much less, so only about a third of our caregivers are helping with self-management support items. And then again, generally a third are helping with medical care support, although approximately half of our caregivers are speaking with the patient's clinicians. So next, we wanted to look at differences in assistance by health literacy. We did not observe any differences in the type of assistance that caregivers are provided by caregiver health literacy. However, when looking at activities of daily living, what we see is that our caregivers who have limited health literacy are more likely to be helping patients with personal care activities as well as mobility activities. Again, looking at differences in assistance by health literacy, specifically for health-related activities. With self-management support, we found that our caregivers who have limited health literacy are more likely to be supporting our patients engaging in exercise or recommended exercises. And while not significant, we have observed a trend that our caregivers with limited health literacy are trending towards supporting our patients with medication self-management. So ordering medications or helping manage medications. And then looking at medical care support, kind of these associations, they change a little bit. What we see here is that caregivers who have adequate health literacy are more likely to be reviewing the patient's health via the portal. And so this was a little bit a change in the directionality of the associations that we'd previously seen. Okay. So now looking at caregiver health literacy and its associations with our patient outcomes. So first, looking at patient comorbidities and number of prescription medicines by caregiver health literacy. We see that caregivers who have limited health literacy are caring for patients who have more chronic conditions. So it's generally an average of one additional chronic condition. We also see that our caregivers who have limited health literacy are caring for patients who have poor physical function. We did not observe any differences with mental health symptoms. And then lastly, looking at urgent healthcare use, we see that caregivers who have limited health literacy are more likely to be caring for individuals who had an emergency department visit in the past 12 months. So been throwing a lot of data on these slides and kind of thinking about all of this together. Generally, kind of what we're observing is that caregivers who have limited health literacy are caring for more medically complex older adults. So older adults who have more chronic conditions, have poor physical function, and have more emergency department visits. And I think that can be seen, that's kind of translating into how we also see that our caregivers who have limited health literacy are also more likely to be assisting with activities of daily living and providing additional levels of self-management support. One other aspect that we've been interested in looking at is whether our caregivers are receiving any training. Only 11% of our caregivers have reported receiving training to help take care of their care recipient. And then among those participants who are speaking with the patient's clinician, only half of those reported that the medical professional asked if they understood the health treatments, and very few, only 17% reported that the medical professional asked if they needed help in managing the care recipient's health treatments. So overall, just we're generally seeing that caregivers really are not receiving a lot of training or support from different medical professionals as they may be assisting patients in managing their health. Okay, so in summary, was hoping to just generally introduce the LitCog caregiver cohort and kind of introduce everyone that we've established this parallel LitCog caregiver cohort. What we found among our caregivers is that they're predominantly assisting with instrumental activities of daily living, and then to a lesser degree, assisting with activities of daily living and some medical tasks. What we're beginning to observe is that caregivers who have limited health literacy are caring for more medically complex older adults, and that overall few caregivers are receiving guidance or training with their health-related tasks. We're continuing this work, and we'll continue to follow our cohort longitudinally to see kind of track these caregiver trajectories over time, and we'll continue to examine caregiver health literacy and its relationship to patient outcomes. And I think one area for future work or future interventional work may be to helping integrate and both onboard caregivers as they begin to assume and support patients with new health management activities. Great. So thank you so much for your attention and for your time. And with that, I will turn it over to Pauline, who will be introducing the LitCog study.
Hi, everyone. Thank you so much for attending our LitCog panel. Today, I'll be introducing the LitCog study, which was recently funded a year ago and directly inspired by the LitCog study. I'll be talking about the development of the study itself and how we approached our study design using a health literacy lens. So an emerging theme throughout our presentations today, I'm sure you've noticed by now, is that our LitCog participants are getting older, and we're finding out that their cognition and health literacy skills are going down as they age. And that has major implications on their ability to manage their health. At the same time, there's growing recognition that these changes in health, particularly cognition, begin in midlife. So intervening in later life is just too late. We really need to focus on interventions across the lifespan, and that's really why we're hoping to replicate LitCog with a younger cohort. How do we define midlife? Well, I think this diagram pulled from a paper by Margie Lockman out of Brandeis University does a good job of that. And it illustrates a myriad of roles, life transitions, opportunities, and challenges that occur during the midlife period. The key point to this diagram is that there are just a lot of events and changes middle-aged adults deal with. And that includes navigating life transitions, marriage, divorce, parenting, careers, and also the beginning of their retirement. They also hold multiple roles at their work, within their family structure, in their friend networks, and they might also have possible caregiving responsibilities for their aging parents, while also simultaneously caring for children. And at the same time, they're also dealing with their own health. This is sort of the period of time where the onset of chronic disease happens, and they might be encountering some cognitive decline as well. And then the chaotic nature of midlife typically translates to psychological distress. So altogether, midlife is just a very chaotic period of time. It's often understudied as well, but it is ripe for behavior change. We do have pretty good justification for doing LitCog with a younger cohort from both a cognitive and health literacy standpoint. So aging is a phenomenon that happens to everyone, yet most aging research focuses on older adults. And in order for our healthcare system to support the needs of aging human populations, we need to understand when aging begins, and we're starting to understand that starts in midlife. We also think that health literacy might be a potentially modifiable factor for later life cognitive decline, and we hypothesize that health literacy will mediate this relationship between age, cognition, and health outcomes. So really, the two biggest reasons why we're doing MidCog with a younger cohort is because we know that cognitive decline is not exclusively a late life phenomenon, and that your midlife health can profoundly shape the course of later life cognition. The way we conceptualized MidCog is a bit different than LitCog based on our findings from the study and also from new research. So in the LitCog framework, which is highlighted on the right side over here, we thought that your cognitive function was determining your health literacy. And that was what was really driving the development of chronic conditions and disease through sort of these suboptimal healthcare interactions, or maybe your inadequate management of your own health. With MidCog, which is highlighted on the left side, we're flipping that on its head. So we think that your baseline health, your health literacy, and these other psychosocial factors are going to dictate how and how often you might be engaging in the healthcare system. And also your ability to live a healthy lifestyle. And collectively, all these factors are going to influence your cognition. The two buckets MidCog really focuses on are going to be these psychosocial stressors over here. So we're specifically highlighting factors in our framework that we also know health literacy impacts. And we separate them by the individual level as well as the systems-based level. So when you think about intervening across this pathway over here, this framework can help pinpoint when individuals should be targeted, when it might make more sense to intervene on an organizational level, and likely when solutions require a mix of both approaches. And also because health literacy depends on the context in which people operate in, breaking down facilitators and barriers, like how it's depicted in our framework here, can also provide insight into context-dependent solutions as well. Our framework is supported by the literature. So this is an infographic from a 2020 report by the Lancet Commission that was able to quantify risk factors for dementia across the lifespan. And so there are 12 known potentially modifiable risk factors: less education in early life, hearing loss, TBIs, hypertension, alcohol and obesity in midlife, and then smoking, depression, social isolation, physical inactivity, air pollution, diabetes in your later life period. And altogether, they account for an estimated 40% of worldwide dementia cases. So our area of focus is here in this blue circle. What can we add to this bucket? And how can our research inform or help people keep cognitively, physically, and socially active in midlife? And how can we do that using a health literacy lens? We know that behavior change is pretty difficult, but if these factors can be prevented, then individuals have a huge potential to reduce their dementia risk. So our study objective is to investigate less studied, potentially modifiable factors during midlife that may determine later life cognitive function and decline. We're hoping that we can marry the two data sets from LitCog and MidCog to explore associations between age, health literacy, self-management, health status, chronic conditions, and cognitive function among adults ranging from ages 35 to 90. We have a massive study battery with nearly 100 unique measures to do this. We have multiple data sources, including information from the participants' electronic medical records at their performance clinic site and outside if they're seeing other types of providers. We're collecting cognitive data from the NIH toolbox. We have, of course, our survey data, and we're collecting physical activity and sleep data using an actigraph. Here we're highlighting all these 4 domains, which we really do think that health literacy may mediate. And so I just want to highlight some of the shared measures we have across both our studies with LitCog and the LitCog caregiver cohort. The red star is shared measures with LitCog, and the blue stars are shared measures with the caregiver cohort. And you can see that there are a lot of data harmonization efforts in place. So for this MidCog battery, we are looking at demographics, but also family history as well. We'll be getting sort of a health profile of our patients, understanding what chronic conditions they're diagnosed with, how many medicines they're taking. Of course, we'll be looking at health literacy and self-management skills. We have 4 health literacy measures in our battery, objective and subjective measures. And we'll be doing a shortened CHAS, which is the same measures that we're using in LitCog to understand health self-management skills. We also have a fairly robust cognitive battery. We have 10 tests for using the NIH toolbox battery, but also using the same paper tasks that we used in the LitCog battery as well. And you can see with our particular cognitive battery that we have multiple instruments for each cognitive domain, which makes this a fairly unique study. We're also looking at function among our patients, vision and hearing, which you know affect cognition, but also physical function as well, with the 6-minute walking test and grip strength. Oops. There's a little bit more in our battery, but oh, here we go. We're also looking at psychological factors like stress and financial stress, patient activation, and personality. And we'll be looking at protective health behaviors and risky health behaviors like sleep, diet, barriers and facilitators to taking their prescription medicines, preventative health services use, tobacco use, alcohol use, and drug abuse as well. We'll be looking at social factors as well, including depression, anxiety, their general well-being, but also trying to understand other factors like social support and their isolation. And of course, we'll be looking at the caregiving roles middle-aged adults have or experience in their current lives as well. And of course, we'll also be looking at how these patients are engaging in the healthcare system. So how often they're seeing their primary care physician, how often they're using their emergency department, what specialists are they going to see, and also how they're taking care of their own mental health. And then collectively, we're hoping to understand how all these factors are going to impact their health outcomes. So we have a series of clinical outcomes we'll be looking at in their medical record as well. The intention of the MidCog study is really to create a cohort similar to LitCog using LitCog methods, and we're hoping to have repeated measures every 3 years to track change. We are recruiting from the same sites that LitCog did, so from one academic medical center and one community health network within the Chicagoland area. And we have really broad eligibility criteria for the study. So middle age, which we're defining as 35 to 64, having no mild cognitive impairment at baseline, and health seeking, which we define as having seen their primary care provider within a year and a half, just so we can look into their medical records. We have 2 touch points with our participants, 1 3-hour in-person interview, and that's looking at cognition and functional health, also health literacy, and self-management tasks. We also have a 1-hour phone interview that's looking at sort of their lifestyle, their day-to-day activities, and how they're engaging in the healthcare system. We'll also be giving participants an actigraph to track their physical activity and sleep for 2 weeks as part of the study. And ideally, we like to do the same set of interviews over time. So there's several things that make this particular study unique. The first being that we're doing this study with middle-aged adults, which very few studies do. We're also intentionally hoping to have a diverse population in our sample. And so we have these quarterly recruitment reports that inform our recruitment efforts. And we're hoping that can ensure that our sample is evenly distributed by race, ethnicity, age, and gender. We're also taking a systems approach to understanding what individualized factors, as well as organizational factors, will affect cognitive decline, and also where to intervene. We also have a fairly robust cognitive battery that's different from existing middle-aged cohort studies. We have 20 cognitive measures, and we're hoping that can really help us characterize cognition in middle age at baseline, and also help us track change over time. And because we are emphasizing modifiable factors in our study design, we're hoping that the way MidCog is designed will highlight the pathways by which social, psychological, economic, and behavioral factors affect health in middle-aged and older adults. So in order for us to combine data sets, we, as I shared in previous slides, we do have shared measures across all of the studies and all of the LitCog offshoot studies as well. We have the ability to validate certain measures and build cross bridges with certain measures that we included in MidCog, but not the LitCog cohort. And for things that we're particularly interested in studying, like health literacy, self-management skills, and cognition, we will transform them into standardized Z-scores so we can directly cross-compare. And then, of course, all of our studies have a longitudinal nature to it, so we're hoping that allows for trajectory analysis when we combine data sets. Of course, while the study is fairly new, we just we started recruitment about 6 months ago. We are encountering a lot of challenges with midlife research participation. These people in midlife are just incredibly busy, and oftentimes they don't have time to do a 3-hour interview, let alone a 1-hour phone call interview. For patients who are saying yes to our research, we're trying to accommodate their schedule by being as flexible as possible. And convenience to them is a big factor. So our team is doing research interviews on the weekends, during the lunch hour, or in the evening time to accommodate their schedules. We're also meeting our participants closer to their workplace or home, somewhere within their neighborhood, to try to cut down on that time. And we're also coordinating our interviews with their doctor's appointments. And of course, that translates, we're finding that people in middle age also want to communicate differently. They really want to communicate on their own time. So that means texting or emailing instead of phone calls. Despite all these efforts, we still have a relatively high no-show or cancellation rate with our interviews, which hovers at around 50%. And because we have in-person research activities, COVID obviously throws a wrench in everything and adds a layer of complexity. We have to screen our patients beforehand. It's just very complicated with COVID. And while this study is fairly new, I did want to end the session about the potential impact that LitCog, MidCog, and the LitCog caregiver cohort can impart. We know that health literacy is both a cognitive and psychosocial determinant of health. And that health literacy is associated with a lot of factors, and that really points to the need for multidimensional solutions, which includes extending interventions to caregivers. Collectively, our findings show that health literacy is strongly associated with cognitive function across all cognitive domains. And I think there are lessons that can be learned from this finding. So, one being, can the health literacy interventions be applied to prevent or slow down cognitive decline? Or vice versa, can interventions for preventing cognitive decline or dementia be applied to promote health literacy? Also, while we're recognizing that lifestyle interventions are often individualized, we could be doing more to create an environment where individuals can easily achieve that through organizational planning and local, national, and safety net policy change. So these are some of the things that I think MidCog could potentially impact further down the road. And then, of course, it always takes a village to do research like this. So I just wanted to acknowledge my team and our collaborators and partners at Northwestern and other institutions. This research really couldn't be done without these individuals. Now I will be turning it back to Morgan, our moderator, for questions.
No. There you go. Hello, everybody. Okay. So the chat is open. If anybody has any questions, feel free to send those along. There was a couple that came through during, which a few have been addressed. Can go through those, but I can give it a minute. See if anybody has any other questions come through first. Well, I'll get started with the first question that came through. It was for Dr. O'Connor. Do you find it common for a caregiver to have the same, better, worse health literacy than their patient they are helping? And we did provide a response. And yes, Dr. O'Connor can do that then.
Playing musical seats here since we're all in the same room, which is nice. Maybe I'm gonna turn it so everyone can see our full panel. Here we are. Okay, so the question was, do you find it common for caregivers to have the same, better, worse health literacy than their patient than they are helping? Yeah, and I thank you for this question. Yeah, so we found that about 2/3 of our caregivers have concordant health literacy, but 1/3 of the dyads do have discordant health literacy, which I think is the most interesting. Where some, it's pretty even split among that 1/3, where where the caregiver may have adequate health literacy and the patient has limited health literacy. And then it's also the reverse where the patient has adequate health literacy, but the caregiver has limited health literacy. I think what we'll be continuing to look into this because I think this is very interesting to kind of keep looking into and better explore. Do you want me to read the next question? Sure. Okay. Or let's see. Doing the chat. Okay, so then
Is it this?
yeah,
Me
the next one.
sure.
Okay. All right. So the next question for Professor Curtis.
Hello. The question is, will cognition explain associations between self-reported measures of health literacy and outcomes? It's an interesting question. I think we don't really know the answer. The relation, self-reported measures of health literacy are kind of getting at something different, and I don't know how, if they would explain associations in the same way. Okay. And this one, I don't know. Do you continue to follow adults and their caregivers after they go into a care facility? I'll answer from back here too.
That's true. We didn't catch everything, but I think we'll, I don't know, like musical chairs. Okay, so do we follow adults and their caregivers after they go into a care facility? So right now we are trying to maintain strong like retention of our participants. If they move into a like senior facility where they live independently, or it's like some level of assistance, but not complete assistance, we will continue to interview our patients and their caregivers. But if they are like in kind of like a skilled nursing facility, or oftentimes their caregivers will, they may decline on their behalf since they just can no longer participate. So we do not continue to interview them once they reach kind of the point where someone else is managing their health like entirely. Okay. Okay, it looks like there's another question. I'm just going to keep going with the caregiver questions. Can you speak to the relationships that caregivers have with their patients? Are there differences in health literacy or reported training in paid caregivers versus informal or unpaid caregivers? Yeah, I think this is really an interesting question because we are enrolling caregivers who are both family members, but also we are enrolling caregivers who are more formal or paid caregivers. I think an interesting side note to also comment in it is that what we found is that some people are also family members, but are also employed by agencies in order to receive compensation for their care. So they are getting this more formalized training through their agencies as well, but are also a family member. So I think this is really like, we'll continue to look into this a little bit more, but there is kind of a unique dynamic going on there. And I think we haven't specifically looked at whether there's differences in the health literacy level by like the caregiver relationship, if it's like a spouse, an adult child, or a formal paid caregiver, but I think that is like a really important next direction to look at. Let's see. So there's also a question about, does health literacy data change at all?
I'm assuming that is in a response to the last question. In terms of the self-reported health literacy measures, if that, please. So I will answer that. And I imagine that would, I think as patients, or yeah, as patients' cognition declines, I think their ability to self-report issues that they're having may be affected. And if that, I don't know if that was, yeah, question. Please let me know if not.
Great. Okay, we're gonna keep going with the questions. Looks like the next one is also related to caregiving. This question is from an individual who works with individuals affected by MS. And they indicate that they definitely observe that many caregivers of those with increased needs do have limited health literacy. My question is based on the spectrum of cognitive abilities and the frequency of cognitive decline in those with MS. What health literacy recommendations would you focus on in this community, if any? Yeah, I think, thank you for this question, and thank you for kind of the work that you're doing among this community as well. I think really trying to support the caregivers, and I think first just like appreciating that the caregivers do have a lot to do. I think there is like an appreciation, and I think there's a lot of consideration for burden and the emotional strain, like rightfully so. But in addition to like this consideration, I think it's also important to consider like how can we support caregivers so they have the capacity to support the patients that they're supporting. And so I think first just like consideration or attention to whether caregivers do have adequate or limited health literacy, I think it is a great first step. And then seeing if people do have limited health literacy, seeing how can you kind of, as you're trying to support these caregivers, what kind of training or capacity building can you offer them as they're delivering their care? All while it's also like it's a balance too, because you also have to, there's a lot of emotional toll. So it's like balancing this capacity building while also kind of trying to minimize burden and promote emotional well-being. Yeah.
Yes, and then I think this follow-up question is me misinterpreting the first question. Yes, it was related to the assisted living. The question is, does health literacy data change after they go into assisted living? That is a very interesting question that I hadn't thought about. However, we have very few people that we are still following, and I think Morgan mentioned it's about 25, but that is something that would be interesting to look at, and maybe we can at least
yeah, I think just like generally with like trying to follow people who have the greatest health needs, but also the greatest change in cognition, like those are the people we would like to follow for research purposes, but like it's difficult because you also have to respect people's like wishes if they would like to not to continue their participation. But also I think it's also just from our standpoint, like trying to meet people and being as accommodating as possible in order so that we can continue to follow them or continue to interview them. I think which I think our team does a like amazing job too.
Yes.
See.
10 minutes.
There's about 10 minutes left. If you have any other questions, please go ahead and send those. I think we can go ahead and wrap things up then, if that's okay. So thank you all so much for listening today. We really appreciate it. And if you do have any other questions for us, I believe our contact information is probably on the website. If you have any more questions about our research or what we're doing here at Northwestern and specifically in Cara.
Like Pastor wanted me to say hi. Hello.
Came on video just for you. You're on mute.
You're on mute.
If I can see. There you go.
Hold on a second. I think I just saw Mike.
Yep.
Yes,
Yeah,
you
I came to
did.
say hi.
Yeah,
We are in your spot after all.
How are you doing?
We are in his
pretty
office.
good. Nice to see you. It's great to hear from your team. I had a sense that maybe you were there behind the scenes, you know, since they were squatting in your office.
It's all good. Very excited to be able to listen to everybody present today, and thanks for all the great questions. So, but yeah, I'm not behind the scenes on this one. I'm just in the audience.
Okay. Fantastic. Great to hear from you guys, and really the trajectory of this work. It's really, you know, really the league leader for this kind of effort, and so keep it up.
Thank you.
Everybody, please remember there's about a half an hour break now, but before the next session, if people would be willing, please check out the posters, and then join us again on the half hour, 1:30 here on the East Coast for the beginning of the next session. Thank you, LitCog team.
Thank you.